board certification in American Board of Internal Medicine, USA. Sir has had an experience as the clinical instructor of medicine in Rutgers Medical School, New Jersey and Illinois University. Sir was the assistant professor of cardiology, University of Alabama. Sir was also an examiner of Alabama Licensing Board, member of Advisory Council to ACC Governor, State of Alabama. Sir is the senior consultant cardiologist, SSSIHMS since 2001 till date. We welcome you, sir.
Cannot delete this. I hope all of you are back here. Please come forward. Back here, no? No, you, both of you come. The morning, I made a mistake. Our two CCT students, both are rank holders in Rajiv Gandhi. They are going to give a talk to you, both of them. Please listen to them. They are a lot of experience and they will try to help you for your exam, how to prepare for exam. And this is Miss Jayasri. She is the MSc student for our CRT, I mean, not CRT, for ECHO. And this is Mrs. Gunapriya. So she is post training now. She is working with us. And hopefully she will join for our MSc program. Thank you, Jersian. So whatever I talk on DSE, that is dovitamin stress echo, will be all from the American Society of Echo guideline. Nothing, anything from outside or any other guideline. Strictly, I followed American Society of Echo guideline. So some of the guideline from NICE or England and Europe may be slightly different, but this is strictly I'm following the American Society of Echo guideline. That more or less worldwide they follow this one. So how do you prepare the dovitamin? How many of you are doing dovitamin stress echo? All of you are doing DSC? How many of are you doing DSC? Nobody is doing DSC? No one is doing DSC? Okay, I'll tell you from beginning. How do you prepare the DSE? Dovitamin comes in 5 ml ampoule. So 5 ml dovitamin you mix with 45 ml of normal saline. Then you calculate according to the body weight. So when a diagnostic test is used routinely, there are three things: patient population, expertise of the interpreter. Most important is quality of the image. Of course, guidelines recommend using three of the contrast echocardiography, but we hardly use it, and most hospitals are not using it contrast during DSE. Ideally, that is what guideline recommends. What are the indications for the vitamin stress echo? Number one, of course, coronary artery disease. To assess the adequacy before and after revascularization. Risk stratification in known coronary diseases, identifying the location of the ischemia, preoperative risk assessment before non-cardiac surgery. Our biggest indication in our hospital is before non-cardiac surgery. Evaluation for patient cardiac etiology coming with exertional dyspnea. They have no chest pain, they come with dyspnea. And to assess valve disease, and in presence of left bundle blood block, and if they have shortness of breath, we use it, very reliable test. And what are the absolute contraindications? Acute myocardial infarction within the first 48 hours. Acute pericarditis, myocarditis, symptomatic severe aortic stenosis, uncontrolled arrhythmias causing symptoms or instability, acute aortic dissection, high risk unstable angina, decompensated heart failure, EF less than 35, acute pulmonary embolism or pulmonary infarction. So relative contraindications are known left main coronary disease stenosis, more than 50% or more, high degree atrial AV block, severe hypertension, 180 by 100, electrolyte abnormalities. See, low potassium patient, you don't want to do a DSE because invariably that will precipitate VT or ectopics. Mental and physical disability, tachycardia or bradyarrhythmia. Then moderate stenotic valvular heart disease. Severe conduction abnormalities like high-grade IV block without a pacemaker. Then active bronchospasm, sick sinus syndrome without a pacemaker, and systolic blood pressure less than 90. Tachyarrhythmias such as atrial fibrillation. Because what will happen if you give the vitamin to atrial fibrillation? Because AV node conduction will go up, the ventricular rate will go up. So that's a relative contraindication. Now, this is a very important slide. It's called ischemic cascade. So what we see when doing a treadmill, we see the ECG. But before ECG changes, what happens in myocardium? See, first the perfusion defect. Where? In the stenotic coronary artery. So there is a perfusion, decreased perfusion. And then it leads to changes in metabolism of the myocardium. Then first thing happens is LV diastolic dysfunction. Then you can pick up by the TDI, tissue Doppler imaging. The next thing happens is systolic dysfunction, that if you do a echo, a stress echo, you see this systolic dysfunction. Then the ECG changes come. Finally, patient develops angina. So when you are doing a treadmill test, patient has no ECG changes, but angina. What do? We ignore him. See, ECG changes, we should be watching ECG changes while doing any kind of stress. Whole 12 lead, you must watch every 3 minutes because there can be changes. Lateral lead could be changes in AVR elevation. What will you do? There is a AVR elevation while doing a treadmill or a stress echo. Anybody? Will you continue or will you stop? AVR as the elevation. Will you stop or will continue? Huh? Yeah, good. Why? See, that could be a triple vessel disease or left main disease or proximal LAD disease. And tight stenosis only will give you a VRS elevation. So this is the protocol as per American Society of Echo, the Britain stress echography protocol. So starting at 5 microgram, every 3 minutes, you go to 10, 20, 30. And 30 itself, if heart rate is not picking up, how do you decide the heart rate? That is 85% of the predicted maximum. How do you calculate that? 220 minus the age of the patient, whatever, so 60 years old, 220 minus 60, 160. So 85% of the 160 is your maximum heart rate predicted for that person. So if you see heart rate is not picking up, don't wait till 40, till 40 microgram. 30 microgram itself, you give atropine 0.25. And especially those elderly people, you ask them if they have glaucoma, if they have prosthetic enlargement, they have taking medications for that. Please don't give it to them because it can set up a precipitated glaucoma crisis and also urinary retention. So elderly people, you have to be very careful about giving atropine. For below 60 years who don't have glaucoma or prosthetic enlargement, you can go up to 0.5, maybe 0.75, maybe 1 milligram. But you have to be very careful before giving. So third is 30 microgram itself, you can start giving atropine. Don't wait till it is 40 microgram. Now, this is a very important view. Already Dr. Satish Govin has showed you. So you have to know these 4 views very thoroughly. See, this is the relation of the coronary artery to the segments of the myocardium. See, 2-chamber view. What you see in the front on the right side is the LAD. And the green is the what? Green is inferior or RCA territory. So your LAD and RCA territory, 2-chamber will tell you. And parasternal long axis view, anteriorly you see what? That is LAD. And posteriorly you see that is circumflex. So these 2 views itself, you know immediately there's a circumflex disease, RCA disease, or LAD disease. Then, of course, 4-chamber view, basal septum, that is the RCA view, and apex and proximal distal septum, the part of the LAD, and posteriorly, that is laterally, you see that is your circumflex. Now, short axis view, again, there are 3 views you can take, but I don't think a machine does not allow you to take 3 short axis view. So take at least 1 view where you can see all the 3 segments of the LAD, LCX, and RCA. See, short axis basal LV, you see so nicely, and mid LV and LV, apical LV. So apical cap is nowadays, we don't use it, but we should watch that if there is a significant thrombus or aneurysm that we have to mention. So when you're counting wall motion score, we don't use the usually 17. So how do you calculate the wall motion scoring? When it's normal? Normal means 40% thickening or more of the any segment of the myocardium is considered as normal. If it is more than 50%, we call it hyperkinesis. Then wall motion score 2, you give hypokinesis of the wall. That is less than 40%. That 10 to 30% systolic thickening. That is important. So 3 is the akinesia or severe hypokinesia, where thickening, systolic thickening, less than 10%. And 4 is the dyskinesia. That means in systole, is eliminated now. We don't use, but while reporting, we should say that there is a diastolic deformation, which is the aneurysmal segment. So if 5 is scored, we don't apply it in the wall motion scoring system. On the basis of this wall motion analysis, a wall motion score index is calculated. How do you calculate? Some of the wall motion scores Then divide by number of segments that you see, visualize. A normally contracting LV with a wall motion score of 1 during stress conferred a benign prognosis that is almost like a general population, 0.9% per year cardiac event rate. If your intermediate wall motion score 1.1 to 1.7 during the stress, not at resting, cardiac events goes up to 3.1% per year. The high wall motion score more than 1.7 or more with an ejection fraction less than 45%, risk of cardiac events 5% per year. So what is dobutamine? It's a beta agonist. It stimulates the beta receptors, increase the heart rate, force of contraction, and conduction velocity. So at low doses, dobutamine enhance coronary blood flow without much increase in heart rate, up to 10 microgram per kilo. At higher doses, stroke volume and cardiac output both increases. So when it increases contractility and tachycardia is induced, it increases myocardial oxygen demand, leading to ischemia in areas supplied by stenotic coronary artery. So there is an inherent disadvantage in dobutamine stress echo. 10 to 15% of patients with those who are overweight or obese or COPD, or they have a poor echo window, either kyphoscoliosis or whatever reason, 10 to 15% cases, what the guidelines say, to use contrast to get a better delineation of the walls. So mainly basal, lateral, inferior segments. It is always a problem. I often see echo report, inferior lateral segment is akinetic. So don't go by that. They mention even in textbook, the inferior wall in echo always looks like akinetic. So you look for thickening. If the systolic thickening is there, say it's normal. So regional function at rest should make note of the segments with absolute thickness 6 or less, which is considered the prior had a transpleural infarction and a scar. So when possible, always better to do exercise. That is more physiologic. Dobutamine is delivered, as I mentioned before, starting at 5 microgram. Then when the target heart rate cannot be achieved with dobutamine, we use atropine. Strain and strain rate parameters can be used to differentiate between viable and non-viable myocardium. So what is the viability with low dose dobutamine? So what is the low dose dobutamine? You don't go to 30, 40 here. Low dose dobutamine used for dysfunctional myocardium. For normal myocardium, we don't need to use low dose dobutamine. It does not help you. So when there's a dysfunctional myocardium, say ejection fraction 35%, 30%, you want to use a low dose dobutamine. Why? Want to see if there's a viability there. In low dose dobutamine, say up to about 10 microgram, you go from 5 microgram and go to 10 microgram every 5 minutes. If patient is on beta blocker, if you suspect patient has single vessel disease, you may have to go to 20 microgram per kilo. Because once you cross 10, the heart rate will go up. To acquire images at the conclusion of each stage is necessity. Protocol is considered completed if there is a 10% increase in heart rate in low dose dobutamine. I'll just give you some data. In meta-analysis of 24 studies, this is you find in the American Society of Echo guideline. Annual death rate is 3% in subjects with viable myocardium who undergoes revascularization, compared to medically treated patients where mortality goes up to 16%. So an optimization of the endocardial border with contrast should be considered for accurate assessment of the volume and EF in patient with ischemic cardiomyopathy. That means patient who has triple vessel disease. So testing for viability is not needed. Patients who have normal myocardium, normal ejection fraction, normal LV size, and is good coronary anatomy, and patient has symptoms of angina. So when do you terminate the test? When the achievement of target heart rate, or if there is hypertension, CBP of 90, or new or worsening wall motion abnormalities, significant arrhythmias, or hypertension 220 by 120, intolerable symptoms. And some of these effects of dobutamine can be reversed by giving IV beta blocker. So ischemic response to dobutamine can be regional or global. So regional responses are hypokinesis and decreased velocity of contraction compared to low dose or at rest. Whereas global ischemic response, EF decreases, cavity dilatation may be seen in left main or multivessel disease. They say cavity dilatation if it is more than 1.7% from previous uh, cavity size. But nobody does this calculation. It is eyeball impression that looks like cavity dilated. When you are doing a dobutamine, you stop the test because most likely patient has left main disease or multivessel disease. You may get into trouble. So normal response, what happens? There's a decrease in diastolic volume and systolic volume, increase in ejection fraction. What are the complications in DSE? That also you have to remember when you are doing a DSE. It is not so benign after all. Potentially life-threatening complications during dobutamine is less than 0.21%. This is from a circulation article. Transient second-degree AV block during DSE has been reported up to 1%. And a transient complete heart block is even rarer. In a large study, 300 cases by Hung, 12 cases had AV block. Both MOBIS type 1 and type 2 has been described. And those who had type 2, they had significant coronary artery disease. So hypertension and bradycardia are not related to severity of the coronary disease. So it's supposedly related to basal geric reflex. It's paradoxically more common with female with normal coronaries. You see, this is during dobutamine stress at the peak doses. You see, this is a MOBIS type 2 block. It's very, very rare, but if it happens, immediately stop the test and try to think about doing an angiogram as soon as possible because this patient has a significant disease. See, the PR interval are fixed. So 2:1 AV block with a fixed PR interval. This is called MOBIS type 2, which is more dangerous than type 1. So in Safdarjung Hospital, Delhi, they have reported a case, Stokes-Adam attack during dobutamine stress. What is a Stokes-Adam? When patient develop bradycardia, hypertension, goes into a seizure movement. We call it Stokes-Adams. So it has been described. So in that case, they have found, it was reported in Indian Heart Journal, found to have normal coronary angiogram, normal during EP study, normal AH and HB interval. So they assume that most likely this is the basal geric reflex. Can you tell me this is the peak doses of dobutamine, the normal heart? What happened now? Tell me, the 55-year-old woman with stress-induced apical what? What do you call it? Anybody? It's called, other name is Takotsubo. It's a normal ventricle, can happen. Takotsubo can happen, apical ballooning syndrome. I've taken from the Mayo Clinic book. So what are the cardiac hemodynamic response to exercise? See, in normal subjects, when you do mitral inflow velocity, E velocity, what happens during exercise? It goes up. Annular E prime velocity is also increases during exercise, normal person, normal LV. So what happens? Sum total of E by E prime remains below 15. Whereas patient who has exertional dyspnea, or diastolic dysfunction, E will increase. Mitral inflow velocity, E will increase. But E prime annular, medial annular velocity either remains same or increases less compared to exercise. So what happens E by E prime? Increases with exercise compared to resting state in patient with diastolic dysfunction. And this has been correlated with a PCW of greater than 20 millimeter mercury. In presence of left bundle branch block, so E by E prime, there is some controversy. Most people will not rely on this. Okay, now somebody can volunteer? There is a quantitation of mitral inflow and E by E prime changes with ischemia. Patient has coronary artery disease. So during the stress test, so look at the changes. Upper panel is on rest. They look at mitral inflow. A is taller than E on the left panel. On the right panel, what happens? E is smaller than A. See, next to before the QRS, this is the A wave corresponding to P. So E by E prime comes to 6.5, which is normal. Now, during exercise, this patient had she changed from left panel upper, left lower. You see, before in upper panel at rest, A was taller than E. Second panel, E became taller than A. What happens to annular velocity? Tissue Doppler? E prime actually came down. So this patient has ischemia, so E by E prime went up to 13 and found subsequently to have significant coronary artery disease. Okay, this is also tissue Doppler. Thank you. So during a tissue Doppler study, see on the left hand upper panel, it's resting, you see, and right hand upper panel, the low the vitamin stress, and left hand lower panel, the peak the vitamin. Now you see that difference? Can anybody say? Resting. Tissue Doppler E is taller than A. No, just before QRS, that is A. So during exercise, what happens? The S prime, which is just above the QRS, S prime goes up compared to the rest at low doses. And what happens to E? Increases. Now at the peak doses, see again, S prime, which is just about above the QRS, which is systolic velocity, it goes down compared to the low dose. And E prime, what happened? Reduced. So there is a biphasic response from this. See, a low dose, there's an increase E by E prime, S by E prime, and then high doses, there's a decrease in S prime compared to the resting. So this is a biphasic response recorded on tissue Doppler imaging. So if you compare, maybe I'll skip this slide. I think it's not for your exam. So anybody can help me with this? This is a polar map display of peak systolic strain by spectral tracking. You see on the left side that ZLS is minus 14. It is low already. And then at peak vitamin stress, what happened to the right? This is ischemia, apical anterior, inferior. The GLS went down to 9. So this patient was found to have a significant multivessel coronary artery disease. So it is beautiful if you can do this, if you have time to do along with the vitamin. So response to dobutamine, there is usually marked increase in regional and global contractility. As I said before, more than 50% systolic thickening is called hyperkinesis, and prominent decrease in LV cavity size due to reduced preload and afterload. So what happens? We don't see hyperkinesis all the time. If lack of hyperkinesis does not mean coronary disease, it could be due to microvascular disease or hypertensive response during exercise or underlying cardiomyopathy. So ischemic response is always defined by development of a new wall motion abnormality with stress in a segment with normal wall motion at rest, or worsening of function, so a hypokinetic segment become akinetic. This is suggestive of ischemia. So physician interpreter report, the very important part of the DSE. The report should include protocol use, exercise time, at a peak doses of the pharmacology agent, maximum heart rate achieved. This is also important. At what heart rate dobutamine is positive? That is also important because that's a prognostic criteria. Very early heart rate at second stage or third stage of dobutamine, you already have a changes on your wall motion. So that patient have significant coronary artery disease. So reason for test termination, cardiac symptoms, side effects, if any pharmacological agent was used, all this should be part of the interpreter report. Again, prognosis I have mentioned once. Now, I don't know how often during dobutamine stress echo you look for TAPSE. TAPSE is, anybody knows TAPSE? Okay, do you do TAPSE in your echo lab? Okay, so in dobutamine also, dobutamine stress echo, do a TAPSE at rest and at peak dobutamine. If there's a 4-point drop, say it was 18, came to 14 or less, that means there's a 90% proximal right coronary artery stenosis. What is a transient ischemic dilatation? The rest to stress LV volume, it goes up by 1.7% compared to the rest. It suggests ischemic dilatation and suggestive of LMCA or triple vessel disease. Now, this is a very older study. Nowadays, this study is not feasible. They have calculated wall motion score at low doses. See, they found that 1.6 and more than 1.6. They followed these people up to almost 4 years. What they found? Those who have wall motion score less than 1.6, there is a higher survival rate compared to those wall motion score more than 1.6. The lower line, see that the mortality is higher compared to the upper line, and survival is much better where your wall motion score is less than 1.6 at low dose dobutamine. Of course, this is unethical today's world. What about the role of DSE in patient who has come to dyspnea? So patient who are dyspneic patient, unable to exercise, referred for DSE. So we look for ejection fraction, resting wall motion abnormality, abnormal left ventricular and systolic volume, response to stress, and failure to achieve target heart rate were independently associated with all-cause mortality. What about LVB? Is the DSE reliable in LVB? Absolutely. No need to send that patient for MRI. Because if the patient has a LVB, it's a normal stress echo, has a very good prognosis, just like a general population, event rate is 0.9% per year. Whereas patient with LVB, an abnormal stress echocardiogram, had worse outcome, mortality rate of 4.4% per year. Then preoperative, before major surgery, vascular, non-vascular, non-cardiac surgery. For patients undergoing non-cardiac surgery, major vascular or non-vascular surgery, a normal study by peak dobutamine conferred an excellent prognosis. They can be cleared for whatever surgery they can undergo. The prognostic value of DSE was at least as good as that of the SPECT nuclear imaging for predicting adverse postoperative events. The heart rate at which ischemia develops during DSE can be used for risk stratification if it is positive. So as I mentioned before, DSE protocol for assessing viability, usually we go from 2.5, 5, 7.5, 10. But if patient is on beta blocker, then it's better to go to 20 microgram to get some kind of information. So considerable information can be obtained on viability testing where there is a dysfunctional myocardium with low dose dobutamine. Utilization of the stress doses enables detection of flow-limiting stenosis by eliciting a biphasic response. So I'll show you what is biphasic response. So when you are doing assessment of viability in dobutamine echo, non-randomized trials suggest that patients with LV dysfunction, significant viability, that improves survival when revascularization is offered to them. The meta-analysis of 24 studies, annual death rate is 3.2% if the viable myocardium who undergoes revascularization, compared to 16% who are medically treated but viability is present. So again, optimization of endocardial border, especially COPD patient, overweight, or obese people, guideline recommend to use contrast. So what is contractile reserve? Do you know how to calculate stroke volume from the echo? All of you know, I suppose. Okay, so the stroke volume at the peak low dose dobutamine, it goes up by 20%. We say contractile reserve is present. If it is less than 20% increase from baseline, these are all in dysfunctional myocardium. I'm not talking about normal LV. So contractile reserve applies to dysfunctional myocardium when you are using low dose dobutamine. The 20% increase in your stroke volume from rest to 15 or 20, usually 20 if you are looking at aortic stenosis. Video. That didn't come that. Okay. Okay. This is the patient with heart failure, and somebody noticed that there is a systolic murmur in aortic area. And echocardiography report was mild aortic stenosis and severe LV dysfunction. Now, would you be happy with that? Let's treat for heart failure. So these are called low EF, severe AS, low gradient severe AS. Next one. Okay. You see on the left upper panel, that is on the rest. So I think read the gradient. Can you read? Yeah. You see on the, this is the rest, upper one. Gradient is 31 by 28. Okay. So what happened here? Low dose dobutamine was started and gradient has gone up to mean 33. And at the peak gradient, at the peak low dose dobutamine, gradient has gone up, mean gradient more than 41. Again, we stopped the dobutamine, repeated the echo, and see gradient has come down, mean gradient 24. So this is called low gradient severe AS with severe LV dysfunction. Okay, I want you to look at upper panel. Upper panel is at rest. And lower panel, we started on the dobutamine, low doses. You don't see any wall motion changes. That X was there, no, X is not there. Okay, go to next. I've gone too far, I think. No, come back, come back. Yeah, this one. So upper panel, you see low dose of vitamin, and no, don't go, come back. Come back. Can you see the changes during dovitamin infusion? In two-chamber view, can you see LED area totally become akinetic? Upper panel, you see normal LED contractility. In short axis view, you see whole anterior wall compared to the baseline became akinetic. Okay, go to next. Run it now. Okay, now top panel at rest. Next is low dose, then there's a high dose, and at rest. Okay, run it. So this patient had angioplasty done outside somewhere in January to LED, anterior MI. Now subsequently patient has come with chest pain. You see any changes there? So anterior wall, you see resting whole anterior wall LED area remain akinetic, low dose or high dose dobutamine. So what it means, it's akinetic scarred area. There is no ischemia in non-LED territory. Now this is the next one. Yeah, run. Yeah. So this is a patient with post-CABG coming with chest pain. You see at rest, upper panel, top panel, a low dose, high dose, and at rest. Absolutely, there was no change. All the wall motion score remained at 1, both at rest and at peak dose, which is a good news for the patient. That means his coronaries are flowing nicely. Thank you. But I want you to ask any questions if you have. They will ask you about DSE in the exam, either Viva or theory. So this is the time you ask whatever question. I may not have mentioned everything. And yeah, you think about it. Any question you can always ask. Thank you.
With the mic. No, this is on. That's fine. That's fine. So as per we had the schedule, we have the next talk, which is mine, which is on strain imaging. So essentially, see this. So as we get ready for the next talk, I request ma'am to give a small token of appreciation to our teacher, Dr. Barooah sir. He's been teacher for both me and ma'am and for all of you indirectly because you've all been our students and Swami's students. I request ma'am to give a small memento of gratitude to sir, though it's a very small in the small terms. Give a mic, please.
Love for the students, the love for the patients is measurable. Be honestly speaking, I know it's a big commitment from your side to be here today. It's an equally big commitment from his side to be here today. All of you will have 100 things you've left and come, no? It's same for him. There's so many things which he would rather do, but he would still rather be with all of you on this Saturday. So I'm very grateful to sir. Sir made his slides himself, okay, which, we were out, sometimes we give it to our students, but he made his slides himself. I'm very grateful to you, sir, for your involvement, your commitment to the cause, really. And today, I think sir is the only consultant who walks 20 times to the Eco Lab, a few times to the TMT lab. Very honestly speaking, at that age, for me, I'm not even sure where I would be at that age. But to see sir's, continuous and there's a zeal to learn. Imagine if Dr. Satish Govind says 3D learning is mandatory. 3D came in a little late to our hospital, but even today, there is better than any of us in 3D. So learning never stops. I request you all to please pay attention for each talk. Please raise your hands if you have any questions. We are not asking you which institute you are from. So nobody knows anything. Never feel shy to ask a question. This is your program. Thank you.
Yeah, put this on, please. Am I audible? Am I audible? No voice. Am I audible? Thank you. There is no PowerPoint, so I'll have to discuss. Let the PowerPoint come on. So, how many of you do strain? How many of you know about strain? Nobody? Fine. You're going to be knowing this or being required to know this if you go for your work from now on, right? No institute is going to buy a new machine which doesn't have strain. And if it has strain, your bosses will ask you to use it. Essentially, what is strain? I don't need a PowerPoint for this. If I get it, it'll be easier for you to understand, but I'll tell you what strain is. You have a certain speckle. You have the echo. You have a certain speckle. You have a certain speckle here. You have a certain speckle here, right? Those speckles move when the heart contracts. So you have a certain distance. Let's say this distance is a starting distance, right? If it's an LV, it's from here to here. Your LV contracts. Yes, as it contracts, those two speckles come closer. Let's say this is L1. The initial was L0. This is L1. So obviously, by maths, your L1 is lesser than L0. Yes? Yes or no? I want participation. So what happens with these PowerPoints is everything remains there. Nothing happens on the other side. I thought I'd actually stand on the back and talk so that you can see this. Your L1 is smaller than L0. You have an L0 becomes L1. You have an L0 becomes L1. L1 becomes L0. Yes or no? This is essentially contraction. So when you look at strain, you are looking at the end length, which is always smaller, L1 minus L0 upon L0. That's all that strain is. If the LV is contracting, it means that your second length will be smaller than your first length. That's why the strain is negative. Obviously, why? Supposing you are at a distance of 5, you go at the distance of 3, it becomes 3 minus 5 by 5. Yes? Because it is smaller than what it started off with. How is this different from left atrial strain? Left ventricle is a contracting chamber. Left atrium is a receiving chamber. Logically, your second length is larger than your first length. Strain in LA is positive. Strain in atria is positive. Strain in ventricles is negative because LV is a contracting structure. That's all that strain is. Okay. Why is it important? You learnt about echo from Sunil, from Dr. Satish. You learnt about DSE from Barooah sir. Why do you need strain? Is it just another hot image add-on? No, it's not. It picks up LV dysfunction much earlier than even your LVEF starts. Essentially, what should happen is when an LV contracts, it all contracts at a certain point in time where the syncytium of the heart contracts together. If you see your aortic valve closure, it should all happen at the same time. Yes or no? It should all happen that all contraction of the heart for that particular myocardium happens at a time in a normal myocardium. Agreed? You have a certain area that is ischemic, and that part does not work. I'll change my slides. And you do not have a contraction of a certain segment, that particular segment will not contract with the others. Yes? Obviously, it will lag behind. If you see the aortic valve closure in time, that segment contracts later. That's why the curve appears later. Am I clear till now? Let's see how this translates in real life. So if we have, thank you. So if we have, if it is the broad outline if I have to tell, this is what I was talking about. What is strain imaging? What is the type of strain? Sorry. Where do you use it? And then what is it good for today? I'm telling you this as somebody coming from outside of your CCT exams. If you do not know strain today, just like Dr. Satish said, you do not know 3D, you do not know strain. All that your institute will expect when you pass out is use this and show me, and you cannot say your BSc didn't have it. It doesn't make sense because they have invested 1 crore on that machine. Obviously, they want, because it's not just about the money, it's about the science that it gives. It gives tremendously good science. It's basically the deformation of 2 points. You got that? I already mentioned it. You have a spring, which if you contract or you elongate will change its length. So supposing the initial one is the one below, this is how your myocardium was. It contracted, became small, correct? So your end length became shorter. So if you went this minus this, obviously your strain is negative, correct? 3 minus 5 is minus 2. So the point is that if you see in terms of the heart, you have 3 axes. You have got a longitudinal axis where it can shorten. You've got a radial axis where you can have thickness and thickening, and you can have a circumferential axis where it rings around. If you see, the heart doesn't really contract like this. It's this way. It's how you ring a wet towel. You have a proximal area, a proximal part which goes in one direction clockwise and the other one is in counterclockwise. It's like this. So when that happens, you get a certain type of strain called as a circumferential strain. And you should know this because when you see the speckles as you do in an echo, right? If I were to blow it up, and then go very close and try to take 2 points in time, supposing 1 point here, 1 point here, this is what I said. Supposing you had 5 millimeter difference, it contracts, it becomes 3. You basically see how much it is as L1 minus L0 by L0. So this is what is the speckle, is what you see. It's also called as AFI. You'd see this sometimes, automated functional imaging. Okay, that's also another name for strain imaging. You can see a quantitative outcome of it, a magnitude or a directional outcome of it. And by that, I mean that if you have deformation, it can happen as a certain force applying it, which is basically the contraction of the heart, in the heart. Clear till now? Strain, I told you, L1 minus L0 by L0. So you start as 8 mm, 8 centimeters is shown here, but whatever, and it becomes 5 centimeters. You obviously know it's 5 minus 8. So you have minus 3 by 8, correct? So it's a negative. Contraction of the LV is always negative. So in terms of strain, in terms of LA, it's a receiving chamber. So it's positive. Strain can be negative or positive is what is mentioned here. Whenever you do strain, you get this, right? I'm sure all of you have seen this. How many of you understood what this is? In very, very basic terms, what is this quad display? You always get 4 outcomes of it. I've tried to keep this talk as simple as I could, right? Because you should understand what strain is in terms of not just being an image. This tells you the kind of contraction that happens. You have a scale there. The best contracting segments are red. The worst contracting segments are the dark blue. So as it goes from here to here, you've got a gradient. It gets worse, 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 and worst. That's how it is. So in terms of this is the overall thing which you get in terms of once you put the endocardial border. Number 1, the overall thing done. Second, you look at this. It gives you the strain of each segment, right? Essentially, you get an overall strain, but is that really important? You get it in the next slide, I've shown it. You get as an GLS of minus 15. How is that important? Yes, it gives you an overall GLS, but that's not what is really important. It is segmental strain that's important because, again, depending on the etiology, particularly if it's a CAD, you are going to look at it in one segment and see for viability, in one segment and look for like whatever, dyskinesia. But then this gives you the overall thing. This is the most important thing for me. Everything in my strain is something I decide from here, which is generally what not looked at, because all of it that we look at is bullseye. Bullseye is not important. What is important is this. Now, this is actually showing you each segment from the aortic valve closure, how early or late does it close, which is what I told you should happen synchronously. It doesn't, it's the dyssynchrony is which you see. In fact, this was taken one step further, and there was a particular point called as TTP, which is time to peak. From here, how much is the time it takes to peak here? The longer it takes to peak, the more dyskinetic it is. Easy? It gets longer and longer in the time axis here. So it gets later and later. All these curves otherwise should happen at the same time. This is basically an M-mode representation of the same thing, which is the darkest is the most homogeneously contracting, then pink, which is little worse, blue is even worse. So the point is to see not only in terms of its deformation, is also in terms of the efficacy or the efficiency of its deformation. This is your quad thing. Okay, so you have a color-coded region of interest overall. You have segmental thing on the top right, where each segment is seen. Each segment's strain individually is shown here. And then you have the M mode, that is the M mode strain. And this is the bullseye. Now, we always look at this. In a way, this is factually, principally incorrect because it tells you the entire thing, but it doesn't tell you in terms of which segment is worse. It's okay for a non-ischemic DCM maybe, but you want to look at regional thing, then you should look for each regional strain. So as I said you, the most efficiently contracting is the red, the most inefficiently contracting is the blue. And that gives you numbers in terms of what is more contracting or not. Now, even if it is normal, one thing that you should understand, and it is obvious, is that if you see a 6+6+4+1 model, which is the ASC model, the apical part of the heart doesn't contract as such, does it? Because it's the rest of the walls that contract. So obviously your overall strain will be negated by this strain, which will not contract because it is just there. You just have an apex, it doesn't contract. So what happens to your average? It comes down. Right. So you basically look at all of these rather than just looking at the apex. The apex doesn't contract really. Then we can see each image separately. We take a 4-chamber, 2-chamber, 3-chamber, whatever. You can see that there is a pericardial effusion in this patient here, and you see that it's all over the place. This is all over the place here, right? They are not contracting at one time. So and you know from this image as well, there is something which is good here, something which is not so good in this because they're all blue. And that tells you that the regionality of the strain in those segments is abnormal. Some few tricks which I have learned from, and this is Thomas Mavick's article, some of the guys who have been real pioneers in strain. First of all, get a good image. Second, try to look for its assessment. Is it adequate for it? You will have a fiducial landmark given by the machine. See if it is correct. Track for it. See your region of interest. And then evaluate the quality of what you are going to get as your output. Because strain is one thing where it is garbage in, garbage out. If you do not have, as was shown also by Sunil and Dr. Satish sir and even sir, if you have a foreshortened image, you're going to get a wrong strain and the entire thing becomes incorrect. Strain rate also can be taken as the rate of strain, the strain expressed as 1 by the actual rate of strain. And a lot of other things have newer come in, which you can read about. I'll not stick to this, but I told you time to peak is the amount of time it takes for each curve. 3D strain has been taken. The most important thing you should remember is which machine you're working with. There is a newer study that we will be part of, and many of your institutes could be a part of, which is driven by the Indian Academy of Echocardiography, where we are trying to look for normal strains in Indians. If I ask you a general number in this place, if I ask you what is normal strain, anybody, what is normal strain? Anybody? -20 is what they say. Incorrect. That's all data from the West. We do not have data from Indians. It may be normal for Indians for that matter. So we are trying to look at what is normal strain value in Indians, which is taken up by the IAE. Always use ECG leads. Never do it without a scale of ECG because you want to look at frequency, depth, the focus. the time gain compensation. You have to look for all of this, because unless you optimize your image, your strain is going to be wrong. Always look at the patient's, it's the clinical history, at least a base of it, because you should know that if it's an anterior wall MI, you're expecting something to go wrong in the LAD leads, right? In those territory and not in the inferior lead. First, you get a good image, allow the machine to give you the outline, correct for the outline, then you get these images. So all of this is in terms of the AVC. So this is AVC, where you have the aortic valve closure. See how early or late each of this happens to give you a bullseye. The clinical applications, I'll stick to very, very basic ones. All of these are there, right? CAD, HFpEF, sir has shown you a few of the heart failure in the morning. Again, valvular heart disease, AS, for example, electrophysiology, a lot of this. One important thing is in cardiac oncology, where you have cardiac therapeutic related drug, when you're giving like chemotherapeutic drugs, that if it causes a strain abnormality, EF abnormality, for example. CAD, very important, can be used even for acute cases. HFpEF has been already discussed, it's been used for the prognosis and the diagnosis. And importantly, when we look at these, I'm not going to look at studies. This is a study from our hospital. This is actually a patient here. A PCI was done in 2014, comes back with chest pain, very similar to what Dr. Barooah sir showed you just now. Okay, looks fairly okay, right? Just some mild hypokinesia here. Not really great. And he had some atypical chest pain. How does strain help us? We did the strain. And you see, it's not so great. Again, it's not, you have to really strain to see that that part is not contracting well. Doesn't look too great on the strain. There is some blue image there. Not great again. You see that it's not very, very blue, not very, very pink. It's just a little shade of red different from what it is on the right. That's how subtle strain is. If you see, did I go back? Yes. So if you see this image, if you really see, this is just a shade redder than this, but not too great. This is what happens. This is how tight the LAD is. Okay, because it picks up very, very subtle kind of blocks. This was a stenting done. You can see there is a tight instant restenosis here in this patient and who underwent an angioplasty eventually. The clinical applications, as I said, are many. HFpEF, heart failure. This is obviously one thing that sir had shown you about the heart failure. You may ask me, you already have EF low, sir. Why do you want anything more from strain? So it tells you which are the dyskinetic contracting segments. This can be particularly used in LBBB when you cannot do MRI, MRI guided studies where you cannot train the heart, when you cannot give a ECG gating to the heart. They always come back saying, no, I can't do an MRI. Your radiology tech will put his hands up. So this is where you can even pick up. You see, you just have a spot of red in the center. As I told you, this is the best part. Gets worse as it goes away from here, right? It's almost like a cherry on top. Cherry on top is seen in amyloidosis. Predicts outcomes in heart failure. Amyloid, I told you, this is the classical finding in amyloid. They ask you this in exams, particularly in your CCT exams, what is called as a cherry on top appearance. The apex gets spared and the rest of the LV gets involved. You can just look at this and have a kind of a pattern recognition. You see that this is normal. You don't need too much logic to see this. This looks normal. Here you have this normal and the apical sparing and rest of it is gone. Here you have the apex gone and the rest of it is normal. That means there's something to do only in the apical. This is actually a reverse Takotsubo. This was amyloid, and this is you have a regional wall abnormality where you have a septal MI. This is the last topic I'm talking on. This is basically if you have if you have a cardiac affection from a chemotherapeutic agent, how does it affect? So these are people who are on cardiac oncology follow-up. They've been given drugs and the LVEF detects it much later. GLS picks it up much earlier, almost 15% reduction from the baseline, which may not even be seen with a naked eye or with an echo. The last topic is on layered strain. This is something new where you can look at strain of each segment. You can look at transmural strain, which is the total strain, endocardial and the epicardial strain. Number one, there's variability in caveats. You should understand that. Software is different between vendors. I told you the same software, same image, one software. This is on the left is from GE, gives you 21, from the right gives you 16. What is normal? GOK. Variability. Same equipments, the same vendor's equipment. If you have serial assessment, you may have change. So do it with good views and in the correct manner. Normal values I already spoke. Nobody knows what is normal in Indians, but we are still going with Western data. So minus 20 and above generally. So if it gets more negative, that means minus 20, minus 25, which is better. Minus 25 is better. As it gets lesser towards zero, that means it is getting worse. So optimal image for strain is absolutely essential. You cannot do it with the right-sided image. Learning curve, they say minimum of 50 studies. Don't fret about doing it. Don't get scared about doing it. Start doing it so that when you are in your second year, third year, or in your internship, start doing it so that when you go outside. I know a student of ours who got a job in Kerala 3 months back. The only thing I knew it because the interviewer was one of our known guys. He said the only thing I asked her was about strain. That's what it has come to. Nobody wants to know whether you can do a 2D today. But can you do strain? Can you do echo? Can you do a 3D echo? So make it an essential. Don't get scared about learning it. Once or two slides about LA strain. I told you I brought this in only to tell you that LV strain is negative, LA strain is positive, because your end length in an LA, it's a receiving chamber. So your end length is more than your starting length. So your strain is positive. It's one of the most important things today to diagnose HFpEF. LVDD, you can have all of this, but LV filling pressure, you don't need an invasive monitoring. You don't need a CAT study. You don't need a pigtail or a wedge catheter. You can actually use this because it predicts prognosis in like in HFpEF when your LV is normal. So in summary, I didn't want to make it too detailed a lecture, right? But in summary, what essentially strain measures is myocardial deformation, whether it's LV or LA. It's basically looking at the starting and the end length. The most common complication is basically for LV. LA has started, RV has started. And now, as Sir said, I take one step further. When you do a DSE, do a strain. When you do a DST, do a LV strain and do an RV strain. It's there in the machine. All that you need to know is like it's just knowledge. Do it. It forms a great data to study at subclinical level how the LV and RV are functioning. Simplified clinical patterns, you can see the pattern recognition. Oh, this looks normal. This looks like amyloid because it's there. It's color coded. You don't need to apply more logic than that. Subclinical is very important LV dysfunction and in oncology and regional variation. What is the future? LA strain. The RV strain is the future. And if you do not know this, as ma'am said, you have to finish your learning here and now. If you feel that you have a degree in your hand and you're going to go out without learning strain, you're incomplete. It's not going to work because it's going to be expected from you as you work in your institutes. Thank you. We'll have the questions at the end, right? We have another 2 echo sessions in the afternoon on on rheumatic heart disease and congenital. At that time, we can again club these questions since we are running short of time.
We had a talk on basic ECG measurements. Can we skip it? Because you will already be knowing all the intervals and everything. Shall we go to the next talk of ECG in acute coronary syndrome? Right. Thank you. Sorry, skipping that. In the interest of time, because we are running a little.
I'm privileged to introduce Dr.Reeta Varyani, ma'am, senior.
Sairam to all. Thank you for paying so much attention. Because for you all, I know it's back-to-back talks. You have to pay attention. Each topic is important. I know it's difficult. We're moving on from echo. We'll take a little bit of a break from echo now. We'll go into a couple of ECG talks. And then after that, we will again go back to echo in the afternoon. And then we'll do some good intervention angios and other things which will help you in your understanding of cardiology. See, cardiology is it's very vast. Starting from ECG, right to the cath lab, right? Since you have to know everything, as much as a cardiologist should know, the technician should know. Now that's very overwhelming, no? Sometimes you feel ki we are not doctors, but we need to know everything. We have to know everything, and these people expect so much from us. Yes, we do expect from all of you. That is the truth. But at the same time, why we are having a program like Crystal, we had one like Facts a couple of months ago, was only for making it a little simple for you. Maybe we're just hoping here that we will add some concepts, add some fundamentals, and hopefully simplify this overwhelming task for all of you. We know how difficult it is. It's like not having done MBBS and then, straight from 12th standard, we're pushing you into a course of cardiology. It's a overwhelming task. I am with you on that. At the same time, we don't have a choice. So you guys, and maybe we think you're all super intelligent. So you all can pick up everything. And we took 20 years to learn cardiology. We expect you to know it in 2 years. Even today, I say I'm learning cardiology, but all of you should know everything at the end of BSc. So I think that's a big task for all of you. But please feel free to stop us at any point. If you feel it's going beyond, we can always revisit what we are looking at. And everybody's here to help with questions and answers. This is again a longish chapter in Shamroth, ECG in acute coronary syndrome. I'll be covering it in about few slides. So all of you know unstable angina and STEMI. Have you all familiar with all those words, right? Right. So we'll just go ahead to the ECGs. This is a common question, one of the questions that comes in ECG in acute coronary syndrome. This PPT I can share with you if you need. Pay attention as much as you can, learn and memorize from the slide. Please go ahead. You don't need to take notes right now. There's infarction, that is the core. The core of the infarct will be necrotic. Around that, there will be some injury, and around that, there will be ischemia, and even there can be ischemia at a distance also. So, what happens with infarction? That is the area which actually gets worst hit. What happens? There are Q waves develop. There's a loss of R wave. There can be some, bundle branch block, RBBP or LBBP can develop, and conduction blocks can develop because the same artery is also supplying the electrical supply of the heart is also coming from there. So you can have either sinus node dysfunction, you can have atrial fibrillation, you can even have AV nodal blocks. Why this is important for you to know? You might be just taking an ECG and a patient might actually be having an ongoing unstable angina, and you might be able to pick this up. At that time, don't ask the patient to go and sit at the doctor's chamber. Take the ECG yourself, rush to the doctor's chamber, give it to them that this patient is having some gross changes. The doctor should look at it immediately. So these are the cases you need to expedite wherever you are, either you're in the ER or in the OPD. While for the injury, it would be very subtle signs like there could be just a broad and tall T wave, there could be ST deviation, some minimal ST depressions, or there could be tall R, which is in the initial periods, and there could be some J point elevation. You might think it's early repolarization, but it may not be. And the far off ischemia could have T wave inversions, they could have ST depressions, and axis might change. These are all very subtle signs which you could miss. So assessing the ST segment is important, examining the T waves, looking for the Q waves, and then finally integrating it with the patient data. The characteristic changes in MI would be ST elevation over the area of damage, ST depression in the leads which are opposite to that. T waves get inverted, the Q waves develop. And where would you look for ST elevation? It should be at least in 2 contiguous leads. Okay, and usually there was a standard of saying more than 1 mm that has changed now, but for all practical purposes, it is 1 mm. In some leads, you need 2 mm ST elevations, 2.5 mm ST elevation based on the age of the patient and all that. And where would you look for it? There is inferior leads, 2-3 AVF, there is lateral leads, 1 in AVL, V5, V6, there's the anteroseptal leads, V1 to V4, like that. So if you talk of a STEMI, you could, very rarely, if it is an in-house STEMI, like in-hospital STEMI, and somebody tells you patients having chest pain, go to the CCU and take a ECG, you might encounter the hyperacute changes. Usually the patient is outside somewhere when this hyperacute happens. Rarely they come within the first half an hour, and you are able to see hyperacute changes. So there will be actually an increase in the R wave height, no loss, please remember. And there could be tall, broad, peaked T waves. So you will feel this need not be a STEMI, but you have to recognize it. A increase in the height of both R wave and T wave can happen in the hyperacute phase. Followed by that, there will be an evolved phase in which the R wave height comes down, the Q waves develop, the T, which was very tall and broad, will start, settling, slowly become inverted, and the J point elevation can come in. QT interval may or may not change at all. And in the chronic stabilized phase, we will have Q waves, loss of R wave height, J point would have settled by then, the STs would have settled, and the T wave will be normal. So if you can see these changes, give the pointer. So basically the cutoff point, the cutoff point for ST elevations is 1 mm is what I said, right? But younger the patient, they expect that there should be, especially in males, there should be a 2.5 mm ST elevation in leads V2 to V3. In other leads, it still says as 1 mm, but only in V2, V3, younger men, 2.5 mm ST elevation should be there. Older men, 2 mm, older men, 2 millimeters. And in women, it could be 1.5 millimeters at least. So this is how I would say this is normal. This is a peak T wave. This is the ST elevation. You're all familiar with all these patterns. You've seen all of this. I can go ahead. So this is like a loss of R, T inversions, and then finally the normal with Q wave. So are you all familiar with the territories? The anterior is V2 to V5, septal is V1, V2, anteroseptal when you say it's V1 to V4. You get a lot of marks. See, we have all corrected theory papers, and that's why I say this. If you write such a thing in the exam, you will get good number of marks for those questions. Anterolateral, you have to include one AVL and V5, V6. Extensive anterior would be both the lateral as well as the anterior. So again, where does the septal come? It's usually before the septal branch. If there's a septal MI, the occlusion has to be before the septal branch. Anterolateral will be after the septal branch, but before the diagonal, because the diagonal supplies the lateral wall. Apical will be if there's the apical LAD. Extensive anterior would be more of a proximal LAD. Lateral wall would be either the ramus or the OM or a early diagonal. And extensive anterolateral could be the left main. This is again important because you need to expedite. You need to give some idea to the clinician that this is what we are dealing with. So, although the answers are written here, would you be able to diagnose this? This is an RBBB with ST elevations, and there's some ST changes even in 1 in AVL. So this could be a proximal LAD occlusion. I'll keep going ahead. Actually, wanted to make most of the talks interactive, but I'm not. I think we will just go ahead. But if you feel we should be slower, then you can let me know. Can you all recognize this as the right bundle branch block? And look at the STs here, right? Very prominent right from V1 all the way to V5. And even in the lateral leads, but one is not so prominent. AVL is prominent. So there are also reciprocal changes in the inferior leads. Where could this MI be? Where would this MI be? Mostly a prox LAD because RBBB has developed. So it is before the septum, before the septal branch. Okay. So this is another patient where there's anterolateral wall myocardial infarction. You can see again there are STs all the way from V5 to V4. There are some reciprocal changes in the inferior leads, but there's also elevation in the AVL. So this is an anterolateral wall myocardial infarction. And extensive anterior MI includes 1N AVL, and you can see subtly the STs are going up in 1N AVL. There's also a VPC, and that can happen too. So what is this? This is what we call a tombstone morphology. It's like a very, what do you call? A terrible prognosis earlier. Now, of course, people take these patients straight away to the cath lab so we can salvage. But if such an ECG was seen maybe 20, 30 years ago, we used to call it tombstone because the patient would invariably land up in the graveyard. So this is what is called a tombstone ECG, and suggests an extensive anterior wall myocardial infarction. You can see right from one in AVL all the way to V5, V6. This is again anterior and inferior. You can make out there's J point elevation and concave upwards ST. So this is in the hyperacute phase where the R is still there, the T has become taller, and the J point is elevated and STs are elevated. And also same things you're seeing in the inferior. This could be a wraparound LAD also where there's both anterior as well as inferior changes. You all know what is wraparound LAD? Type 4 LAD we call it. You've been in the cath lab, most of you? Most of you gone to the cath lab? You know coronary anatomy and all that? All right, no worries. Then there's an inferior wall myocardial infarction where you will see all the changes, especially the elevation in leads 2, 3 and AVF. Again, we could have hyperacute T waves, we could have reciprocal changes in the anterior leads. So this could be either infero-posterior, infero-lateral, where there's an extension. So inferior, is 2, 3 and AVF, right? So if it is lateral, you can add 1 in AVL to it or V5, V6 to it. If it is posterior, you can add leads V7, V8, V9 to it. And sometimes we do not do the V7, V8, V9. So we look for mirror image in lead V2. Posterior wall MI per se could be a 3 or a 5 mark question for you. So it's good to know that. So RCA occlusion, how will we see? You see 3 more than 2. Anytime you see 3 more than 2, you're dealing with RCA. Anytime you see 2 more than 3, you are dealing with a LCX occlusion. Is that easy to remember? 3 more than 2 is RCA. 2 more than 3 is LCX. At least for elevation. Okay. We start with remembering just that much and then we can take it forward. So this is, of course, a V4R lead. Where is V4R lead taken? On the right side, are you aware? V4R, right-sided leads. So sometimes we have to take this V4. Whenever you see an inferior wall MI, don't stop with taking a regular ECG. Immediately take a right-sided ECG as well. So we have to diagnose RVMI. We have to diagnose if the occlusion is before in the proximal RCA or in the distal RCA. So which artery is occluded? Is it RCA or LCX? Like I said, 3 more than 2 is RCA, 2 more than 3 is LCX. There are also other features. You can go through this later on. But the amount of reciprocal changes that you see in leads V1 to V3 will be a lot more in the circ occlusion than the RCA occlusion. So that's how these parameters come in. And even V3 depression is a lot more in LCX than in RCA. So this is one of the examples where there's an occluded RCA. You see 3 is much taller than 2. And then there are reciprocal changes. But you see V1 to V3, it's not so gross. So this is more of a RCA occlusion. And on the other hand, you see this ECG. This is 2 more than 3. But you look at the ST depressions in V1 to V3, they're gross. Can you make out? Just you don't even need to make measurements. This is a lot more prominent. The ST depressions here are a lot more prominent than these ST depressions, right? So whenever you see the reciprocal changes are more, that could be a circ occlusion. And again, this is a massive infralateral MI where you have all the inferior leads, plus you see the lateral leads, so much of ST depressions, and 1 in AVL and V5, V6 are showing ST elevation. Like I said, you can have conduction blocks in cases of inferior wall MI. You could have bradycardia, you could have AV blocks because there is ischemia of the AV node. So these conduction blocks, they could be like in a patient in the ER, in the emergency room, you might say, to the physician, there's just a first degree AV block. By the time you shift the patient to the CCU, there's a second degree AV block. And by the time you shift the patient to the cath lab in the next 15 minutes, it might be a CHB and there might be an arrest. It could happen that way, or you could directly see a CHB at the first encounter itself. So both of these could happen, and you should be aware of this. So this is a CHB. You see there is no relationship between the A and the V, and there is a massive MI here, 3 more than 2 RC occlusion. This is another case where there is sinus node dysfunction. As you can see, there is an inverted P here. There is some P wave here, but there's a junctional escape here. So it can affect even the sinus node. And then even RVMI comes as a theory question for you separately also. So you should know about RVMI whenever there is an RC occlusion before the origin of the which artery? There's a branch, no? What is that branch called? What is that branch called? The RV marginal branch. Have you seen it in the angio? Any of you? Okay. We will be going through basic angio in the afternoon. We can see it there. So in patients who've got RVMI is suggested by elevation of 1 mm or more in either lead V1 or in V4R. Okay. Now RVMI usually does not occur as an isolated phenomenon. Usually occurs with inferior wall, but rarely it can be isolated also. So ST elevation can be there in V1 and there can be ST depression in V2, and again RCA will be occluded. So the clinical significance, yes, it is there because these patients can have more hypotension than the others than a regular inferior wall MI also. And so this is the right-sided leads, as I said, and this is another example of elevation in V4R. You can see there's ST elevation in V4R, and there is 3 more than 2, and there's ST depression, which is not seen here, of course. But in this, we can make out there is ST depression in V2 also. This is an RVMI. Then posterior wall MI is again, like I said, either you take V7, V4, V8, and V9, or you take V2, lead V2 only, and you will get a mirror image. This is a mirror image. You see that there is a preserved R wave, there's a J point depression, there is a ST depression, and there's a positive T wave. So if you see, this is what you will see on the surface ECG, and this is actually the inverted image. Can you see that this is V2 inverted? They've just taken a mirror image of this, and this is how you look. So this, when you see the mirror image, you see a Q, you see, that there's an ST elevation, J point elevation, ST elevation, and inverted T waves. See, earlier we used to get printed ECGs. I'm not sure how many of you get printed ECGs today. But when we used to get the printed ECG, we used to just turn it over and we say, yeah, there's a posterior wall MI. But today everything is digital. So you can't invert anything really, with the digital image. But that's why you need to be more alert when you see so much of ST depression and a tall R. So you have to look at V2 all the time. Okay. And like I said, this is the posterior leads. You need to know their location as well. Axillary line, scapular line, and paraspinal or paravertebral line. And this is examples of V7, V8, V9. You're seeing the STs. And then the inferior infralateral STEMI, where you can see both inferior and lateral also. V5, V6 shows elevation. And this is another patient with a posterior MI. You can see there is a tall R, and there is some ST depression and a T wave. And this is another patient where they have recorded V7, V8, V9. Then only lateral STEMI will have changes only in V5, V6 and 1 in AVL. Here you can see clearly, this is 1 in AVL showing ST elevation. Of course, there's reciprocal depression in the inferior leads. And this is a patient again with a recent high lateral MI where the changes have now become like a chronic stabilized phase. This is an example of an anterolateral STEMI. Introlateral STEMI, we went through this. And now coming to non-ST elevation MI. So here in non-ST elevation MI, you do not have a complete occlusion of the artery. STEMI was always complete occlusion of the artery. And STEMI is not. So you could have ST depressions, you could have T inversions, both of them, or you could even have a normal ECG. So this is Wellens syndrome, also called as Wellens sign, where you can see deep T inversions, and even biphasic T is now included in that same thing. So it could be either a biphasic T like this, or there could be deep T inversions. But you look at the ST is almost normal. So very important to remember, if you don't see ST elevation, don't say there's no MI. Whenever you see deep T inversions or biphasic T, the patient has to be revascularized at the earliest. So Wellens syndrome could come as a standalone question, but usually it does not come as a standalone question. So there will be no Q waves. Okay. And the other thing is that all of this deep T inversions and all could happen when the patient is having totally pain free. So patient is lying down in front of you and is totally pain free and is having deep T inversions. What happens is when the patient actually has pain, there is pseudo normalization. So this deep T becomes a normal T. Okay, so you should know this. You will say there's deep T inversion, there must be something, but the patient says I don't have pain right now, and then you'll be confused. So the deep T happens in the pain-free state. And the pseudo normalization can happen when the patient is actually having pain. Again, this is another sign, De Winter sign, which was, discovered long back. But how many of us use these things in clinical practice is what we need to increase. More and more of us should be aware of it to, use this in daily parlance. So De Winter's sign is again, the criteria are that there will be tall, prominent, symmetrical T waves. I can show you this. So you see there is a J point depression, there is ST depression, and there is a tall, broad, peaked T wave. So this is what is described as De Winter's T waves, and De Winter's sign says that this could be present in acute LAD occlusion, and so we need to recognize it with urgency. This is another example of De Winter sign. You can see that there is a J point depression, upsloping STs. Upsloping STs, the T wave, the ascending limb starts well below the baseline. Okay. This is another example of the same thing. The T wave is starting well below the baseline. There's J point depression. And again, this is left main artery. All of you know left main, no? Left main, you would have heard of left main disease. So left main is one of the most critical arteries because it supplies the entire left system. So either you have a triple vessel disease or total left main. You can have ST elevations in AVR. You see here, AVR and V1 will show ST elevations, and there will be global changes. There will be global changes usually. So ST elevation in AVR could include left main. Sir? Yes, sir. Sir? Yes, yes. Yeah. So when TMT is going on, no, you should look for ST elevation in AVR. What happens is this is a sign which should prompt you to stop the TMT test immediately. Do not proceed. Even if the patient says he's okay or you're not seeing any BP fall or anything of that sort, ST elevation in AVR could mean left main stenosis or even rarely proximal LAD, or it could be just triple vessel disease, but critical triple vessel disease. So you should watch out for ST elevation in AVR. So this is another example where you can see global ST changes and ST elevation in AVR. Similar thing, you can see Q here, AVR, but okay, there's ST elevation in AVR, and that is not a good thing. Similar thing. So this is more or less a summary of what you should know. This is a conventional STEMI where you have J point elevation, and there is, and this is the hyperacute phase, of course, where T is broad and tall. And then there is De Winter sign where there's J point depression. There is an upsloping ST, and then the T wave, which is tall and broad, peaked, but it starts below the baseline. This is the posterior STEMI seen in V2. These are the hyperacute T waves, which are seen in hyperacute MI. You see the T is so tall and even R is preserved. Then there's valence A and B, biphasic T's, deep T wave inversions. Garbusa criteria, I didn't touch upon it, but it is anterior wall MI to be diagnosed in the presence of left bundle branch block. And then there's shark fin appearance and acute ischemia in the presence of left ventricular hypertrophy also. So thank you so much for your attention. you can learn all this very easily. In fact, the whole of ECG can be learned if you keep paying attention to the ECGs. Many technicians, I'm including my institute, our institute, they go there. They don't know what is an ECG, how to interpret, but they know this is the way to connect the leads. They'll keep connecting the leads. You can prepare the next presentation, and they'll do that, and then they will enter. Entering is very easy, no? Monitor पे entering the computer may I entered the number correctly, and I gave token to patient. I took token from patient. All that everybody can do. Once the ECG comes on your screen or in your hand in the print form, please look at it. This is my only request to you all. Please look at the ECG. And if you look at that ECG, I'm sure out of 10 cases, at least one you will recognize that no, this is abnormal. I need to take this to the doctor. Just do this one thing, you will start learning ECGs and you learn them really well. And let me tell you, just to increase your confidence, most of us in MBBS did not know ECG. Most of us learned ECG only in MD medicine thoroughly. Our thoroughness in ECG, whatever we know of it today, our basics were in MD. So for you people, you're straight away taken into an MD level. It is not easy for at an MBBS level. So maybe the first year you can skip. So first year is your MBBS. And second and third years of BSc technology are your MD degrees. Okay. So second and third year, don't miss looking at the ECG. Who's next? AV blocks. I think Madhav is doing. Can we have Narendran finish his talk? We will do AV blocks a little later. I want to look through your PPT. Is it okay, Narendran? Can you make his? We'll do. He's got 82 slides. I cut.
No, as this is going on, is it ready? Yeah. As this is going on, I'll ask a question. If anybody answers this from me, this is one prize for today. One extra sweet in the afternoon. Unfortunately, this phenomenon was mentioned during the COVID time. And any of you have gone through it, other than talking and thinking about COVID, you would have heard this name. This is called as Aslanger's pattern. Anybody can tell me what this is? Including our own guys. I haven't taught you that yet because I kept the question for now. What is Aslanger pattern? It's related to what ma'am discussed. ECG and ECS. No Googling allowed, obviously. Anybody? See, she started. Jayashi started with that. Google Amba. Tell me. I want all of that. Give her. I want the entire pattern. What is the pattern? What is Aslanger pattern?
Is it OM occlusion?
It's not OM occlusion. It is not. It is about OM occlusion. But then what is the pattern? Put the mic on. He gets half the sweet for sure. But the thing is to understand it, why it was described. What is Aslanger pattern? You are doctor? You are? You're an MSc student. Good. Why don't you just put this thing on? Yep. They have a pattern about it. It was described for the OM. Actually, there's something that comes very close to that. What is the other thing? It's called as the South African flag pattern. So exactly how do they differ? Now, for that you need the full suite, you need both.
In South African pattern, in D2 also there is some difference.
Just imagine how the thing is. It's very easy that way. You have a 12 lead. You have a South African flag which goes like this, right? The sideways Y. It's these, right? Yeah. There. Sorry, it's there, and there. That's how it is. That's how you have a South African flag. So a Aslanger pattern is basically, it's seen in OM occlusion, but then it's ST elevation in 3 without having ST elevation in the other inferior leads, 1. 2 and F will not show it. Only 3 will show it. Number 1. Number 2, V4 to V6, where you have an upright T, you will have ST depression. ST depression in V4 to V6 in the upright leads. That is V4 to V6 in the upright leads, T upright leads, you will have ST depression. And third, ST elevation in V1 but not in V2. So those 3 things together is called, yeah? Those 3 things together is called as the Slanger pattern. It was described for OM occlusion where you have ST elevation in 3 but not in the other leads. ST depression in V4 to V6 but not in the other V1 to V3. You don't have ST depression, and you have V1 ST elevation but not V2. Good. Anyway, you get the sweet. Thank you. Actually, if you know this, a Slanger described it in dominant circulations. Because you have only left dominant, then opening that becomes very important. You don't have an RCA, for example.
Good afternoon to everyone. So today I'll be presenting some information on AV block and interpretation. So coming to the basic conduction system of the heart. So as you can see, this is the right atrium. So as you can see, this is the SA node. This is the AV node. There are 3 bundles connecting AC node and AV node. This is the bundle of his and dividing into the bundle branch, left bundle and the right bundle. Left bundle again divides into anterior and posterior. We'll come to that later. Going to the next, this is the diagrammatic representation showing the left bundle dividing into the anterior fascicle and the posterior fascicle. So this is the PQRS T, how the atrial depolarizes, the depolarization is complete, and QRS represents the ventricular depolarization, and ST segment represents the ST ventricular depolarization. So coming to the intervals, so you have been, yes ma'am. So coming to AV blocks, basically there are 3 types of AV blocks: first degree, second degree, third degree. Second degree is again classified as type 1 Mobitz, type 2 Mobitz, and so to get a fair enough idea, there is the heart block poem. If R is far from P, then you have a first degree AV block. If R from P is longer, then and then a drop, then you have Wenkebek. And some P's don't get through as R, then you have a Mobitz type 2. P and Q don't agree, they have an independent working of their own, then you have a third degree. So first degree is defined as the PR interval of more than 200 milliseconds, denoted by the 5 small squares. And if it is more than 300 milliseconds, it's denoted as a marked first degree AV block. So this is the ECG strips showing first degree block. You can see the PR interval here. It is more than 5 small boxes. So what are the causes? Causes can be, the basic causes first, electrolyte disturbances, drugs such as beta blocker, digoxin, amiodarone, may be a normal variant in some people, in increased vagal tone and athletic training, in inferior wall MI, patient post mitral valve surgery, or patient after myocarditis. So it is not of much clinical significance as if it is an isolated finding. And this you can see the example of marked first degree AV block around 340. So here you can see an ECG showing normal sinus rhythm with first degree AV block. So coming to the second degree AV block, it is Mobitz type 1. Mobitz type 1 is also known as the Wenkebek phenomena, prolongation of the PR interval until a P is dropped. So here you can see PR is, this one is longer than this one is longer than this, then ultimately a P is dropped, a QRS is dropped. So this is a Wenkebek pattern. So coming to the causes, drugs, vagal tone, inferior wall MI, myocarditis following a cardiac surgery at a mitral valve repair, TOPS repair. And the other features are PP remains constant. The PR interval is greater typically between the first and the second beat of the cycle, and RR progressively shortens. And there was a repeat pattern of after 3P, 1 QRS will drop, or after 4P, 1 QRS will drop, after 5P. And usually due to a reversible conduction block of the AV node. And this is because the malfunction in AV nodal cells progressively fatigue until they fail to conduct. They work, and then they get into fatigue. So yes, coming to the ECG, here you can see the after every fifth P, there is a drop of QRS. So this is a example of a type 1 Venkapak. This is another example. There is a beating in groups like 1, 2, 3, 4, again drop, 1, 2, 3, 4, again drop. So here we can see there is a ECG of an inferior wall MI, ST elevation in the inferior leads with ST depression in the V2 and V3 with PR prolongation, and there is a drop. In the long rhythm strip also you can see there is a PR prolongation and a drop. So it can be associated with inferior wall MI, RV infarction, and majority of the association is 2:1. And second degree AV block, there is a fixed blockage. After every the PR is interval is constant. There is no PR prolongation. So here you can see after every 2P, every third P, there is a QRS drop. So P, you can see the PR remains constant and P valve marches as a constant rate, and this is a fixed block. So this is usually due to failure of conduction below the Purkinje system, and most likely due to the structural damage of the conduction system, unlike the Mobitz one, which is the functional fatigue, and patient might have pre-existing fasciculus block or bundle branch block. So it can be present in anterior wall MI due to the septal infarction or cardiac surgery or inflammatory condition, myocarditis, infiltrative disorder or hyperkalemia, or due to drugs. So it is it might lead to hemodynamic instability, and there is a risk of asystole of 35% per year. So coming to the fixed, this is a 2:1 AV block. Here you can see there is a 2:1, and here you can see there is a 3:1 block, and the third P wave is concealed somewhere here. And this is the 4:1 AV block. This is a high grade AV block. The atrial rate being around 140, but the ventricular rate is around 30. So high grade AV block is when the PQRS ratio is more than 3:1, and extremely slow ventricular rate. Here is another ECG. So I'll come to complete heart block. It is severe bradycardia due to absence of AV conduction. The P and Q they do not agree. So there is a dissociation. So A will be beating at an independent rate, and yes, usually the atrial rate is more than the ventricular rate. So here you can see the PR interval here is a different, here is a different, and here is a, however, the P interval and RR interval are constant. So it can be as an endpoint of Mobitz type 1 or type 2, and it may be due to onset of complete conduction failure. It can be secondary due to infarction, and it can be due to drugs also, or idiopathic degeneration such as Lenegre's-Leves disease, which is due to ECG. So this is example. Yeah, ma'am. So this is the ECG showing CHB with inferior wall MI. Here you can see that there is ST elevations in 2-3 AVF plus posterior wall changes V2, V3, plus there is a CHB. Sometimes mostly they revert after revascularization. So this is another CHB with a broad QRS complex, and here you can see the QRS complex is broader. So here is another ECG where ventricular rate is too slow. Patient needs an immediate temporary pacemaker or some pacing assistant or atropine. So this ECG looks like a 2:1 AV block, like it looks pretty fixed, but it is not. If you can see the long rhythm state, there is no relation between the P and R. So it is called an isorhythmic AV dissociation. There is a chance association that is, it looks like it is an associated AV block, but it is not. And coming to the types of AV block, it can be suprahesian or infrahesian. Suprahesian can be above the AV node, and infrahesian is below the AV node. Usually type 1 is of suprahesian nature and type 2 is infrahesian. So coming to the, if it is in AV node, it is called suprahesian. ECG, yes, ma'am. No. So here you can see there is a QRS is narrow in this CHB. So this is a suprahesion. In this type 1, it is suprahesion. However, in this one CHB I have shown you, the QRS is broader. So it can be infrahesion CHB. So after this, I would so the basic story of AV block family. So what happens in normal cynicism? The P is the wife and QRS is the husband. So in normal cynicism, the wife will wait for the husband, and every time the husband will come home. Yes, sir, that's why AV block will. So now different types of AV blocks. Yes, sir. So, yes. So in first degree AV block, the husband will come, but he will come a little late, but he will come. Second degree AV block in type 1, he will come every day. His arrival will get late. Then some one of the night he won't come at all. Then in type 2, there will be a fixed days, like on Wednesdays or Sundays, he won't come. Oh. Yes, sir. So why after that it goes to third degree, they have to live separately. The wife doesn't agree for all that behavior, then so he comes whenever he wants. So this is the ECG. So bundle branch blocks. Okay, thank you.
And you have lunch in the canteen and please come back, please. Thank you.